Good afternoon, everyone, and welcome to our Aging at Altitude series. Thank you so much for joining us today for our lunchtime webinar conversations. My name is Lindsay Haynes. I am the event manager with Prairie Mountain Media, and I will be moderating today's session. So our webinar format on Zoom gives you the opportunity to ask questions via our chat box or our question and answer box that you can find at the bottom of your Zoom screen. So whether you're on a tablet, a phone, or even a computer, you'll just hover over the bottom of your Zoom screen, and at any point during our speakers' presentations today, if you have a question, just input those there, and then we will address them once their presentation concludes. So today's session will cover eye health, and we have the opportunity to hear from two different speakers, both from the Eye Care Center of Northern Colorado. So we'll start off with Dr. Matthew Manry. He is going to take care of age-related macular degeneration, and then we'll switch to those question and answers. And then followed with that, we'll have Dr. Melissa Burton. She will cover blurry vision, common causes in the aging population. So that being said, I will go ahead and turn it over to Dr. Manry to get us started.
Thank you, Lindsay. Appreciate being able to join with you guys today. I am Dr. Manry, and as I'm working to open up my presentation, if any of you were around, I did give this talk on macular degeneration last year, but I did update it for 2021 on the other side of pandemic, as we have gotten some new information and some new data and research. So happy to be with you guys today. We'll talk about how the eye works, what is macular degeneration, how we treat it, and then leave some time to answer questions at the end as well too. So a little about me. I am an ophthalmologist and retina specialist. I joined the Eye Care Center of Northern Colorado about 2.5 years ago in 2018. I was born in Pennsylvania, but grew up and spent most of my life in Florida. Before undergraduate training and then medical school in Florida, I did my residency at the University of Michigan and fellowship at the University of Cincinnati and the Cincinnati Eye Institute. So the Eye Care Center of Northern Colorado is one of the main comprehensive eye care groups in the area. We treat all sorts of eye conditions, cataracts, glaucoma, macular issues such as diabetic eye disease and macular degeneration, along with comprehensive eye exams, dry eye disease, etc. We have 4 offices that we go to. Longmont is our main office, but we also are in Boulder and Lafayette, and occasionally we go up to Greeley to see patients in Greeley as well. So here's a brief overview of the eye. The eye is a fairly complex piece of medical anatomy, but we kind of think about it a little bit like a camera. So in the front part of the eye, you have the cornea and the iris, the colored part of the eye. Behind that is the lens, and this is what the lens is involved with when it comes to cataracts, and needing cataract surgery is taking the lens out and replacing the lens. Inside the eye, there's a large cavity here called the vitreous, which is mostly water, but it has collagen and some other structures. It's part of what people get when they have floaters in the eye. You can see here the retina is kind of our reddish orange color with blood vessels in it. And we think about the retina like the film of a camera. It's the light sensing organ that picks up light. And the optic nerve is what sends the signal back to the brain and connects to the brain to transmit that information. So like we talked about, the eye is kind of a camera, and the retina is the film of that camera. So not very easily replaced if there's any issues there. This is what we call a color fundus photograph, but this is kind of what it looks like when we're looking into the eye and looking in the back of the eye. You can see here this kind of orange disc is the optic nerve. This patient has a very healthy optic nerve with no evidence of glaucoma here. You can see arteries and veins are both present. This photograph is focused on the macula right here. And the macula is kind of a postage stamp area, but what allows us to see clearly, and specifically the fovea right here in the center is what really allows us to see clearly. So what is age-related macular degeneration? It's a leading cause of severe vision loss in people age 65 and over. It's not a part of the natural age process and is usually present in both eyes, but maybe asymmetrically, one eye worse than the other. So as we see over time, the prevalence in our society goes up in terms of the number of people who have macular degeneration, but a fairly sizable amount of our population has that. And you can see normal vision on the left side here. And then patients who have macular degeneration are going to have kind of a blind spot in the very center of whatever they're trying to look at. So if it's something they're trying to read or faces, that can either be blurry or actually missing and absent. Well, who are the people who are at risk? Age-related macular degeneration has age in the name, so that's really one of our main risk factors. We typically are not going to see it in younger individuals. A family history of macular degeneration, primarily in parents or siblings, is going to put someone at higher risk. Cigarette smoking and tobacco use is a big risk factor for developing macular degeneration, and especially for the progression of macular degeneration. People that smoke are at a much higher risk for macular degeneration, become very advanced. And people who have dietary issues, so low vitamin zinc or antioxidants in our food. Other things that are possibly risk factors but less determined are going to be things like your iris color, heart disease, hypertension or high blood pressure, and living in a sunny place like Colorado could potentially put someone at higher risk. One of the questions that we usually get is, does cataract surgery or cataracts impact macular degeneration? And the answer is no. We've looked into this very detailedly, and getting cataract surgery does not make macular degeneration worse. And a lot of patients who have macular degeneration will often see a benefit from undergoing cataract surgery. So as I discussed on that earlier slide, macular degeneration can cause kind of a blind spot or a portion of the vision that's out of focus or missing in the very center. It can also do things like cause little areas to be missing or for things to appear distorted and bent. This chart right here is what we refer to as an Amsler grid. So this is a kind of a standardized grid that we'll use to check patients' vision either in the office, and sometimes it can be done at home. And ideally, one eye at a time is checked and looking to make sure that the lines are evenly spaced with no areas that are missing. Right here on this side is an example of different macular conditions that can occur, but distortion in that grid. And this can be due to a multitude of things: macular degeneration, diabetic eye disease, epiretinal membrane, macular holes. There are a lot of things that can cause this, and it's typically, if you see something that's distorted like this, you may need an eye exam with your eye specialist to better determine what the cause of that is. So when you come in for a normal eye exam with optometrist, ophthalmologist, or retina specialist, here are a few of the things that they may do to help evaluate this. Photographs, like we talked about, an OCT, which is an image that's kind of a cross section of the retina that shows us the different layers of the retina and deposits beneath it. In this color photo, we see these kind of yellowish spots, are what we call drusen, and these are one of the main markers of macular degeneration. These drusen are actually beneath the retina, and on this OCT, you can see them right here as kind of this little bit of a sawtooth pattern beneath the retina as drusen. Another part of the evaluation that's typically going to be done by a retina specialist is going to be an angiogram or fluorescein angiography. And that's a test where we inject a dye through a vein, typically in the arm, and we're actually watching blood flow through the eye and looking for areas of abnormal blood flow or areas where that dye is leaking out. And that's a diagnostic test to look for macular degeneration, specifically maybe when we're looking for wet macular degeneration. So we'll talk about the different types, dry versus wet macular degeneration, and how they differ. But think about wet macular degeneration as kind of a branch off point from dry macular degeneration. So in more of the mild or moderate stage macular degeneration, it may have this appearance and it can progress with atrophy to an advanced stage, or we can get wet macular degeneration, which we'll talk more about in a minute. So dry macular degeneration is the most common form. Vision loss is typically gradual, and a lot of patients may at least initially be minimally or have no symptoms. There can be the deposits of drusen, like we talked about, beneath the retina, with damage to the retina that causes thinning and atrophy of those tissues. In the early form, we will see just a few small drusen that are of minimal significance. When it gets into the intermediate form, it'll look a little bit more like this picture here. And the late stage and advanced forms have areas of atrophy. So these are portions of the macula that simply just stop working and die off because of unhealthy tissues that can no longer support the health and viability of the retina. This is another example of these atrophic or thin patches. And you can see the blood vessels that are beneath the retina in the layer that we call the choroid kind of shining through, almost like we're looking through a window here. So how do we treat dry macular degeneration? Well, we already talked a little bit about tobacco use as one of the factors, but one of the mainstays of treatment are vitamin supplements. The AREDS-2 study is the age-related eye disease study, and this is the second trial that was done. And basically, in addition to a standard multivitamin, looked at higher doses of vitamin C and E, lutein and zeaxanthin, which are very specific antioxidants that are found in the retina, and zinc and copper. And these vitamins were shown to statistically significantly reduce the risk of progression of macular degeneration, specifically in terms of going from the dry form to the wet form. There are a lot of different eye vitamins out there, and it's really important to kind of look at the label and look and see what you're taking. A lot of times there may be doses of lutein and zeaxanthin that are higher than what we found in the AREDS-2 study, and that's usually fine. We're usually looking for those to be kind of a bare minimum dose that people are taking. But you'll want to kind of just look at the label and compare what the ingredients are on the label to what we have in the AREDS-2 study as kind of our gold standard is what we want to be taking. A healthy diet is one of the factors that plays a role here. So the Mediterranean diet is good, a lot of fish, olive oil, things like that, and green leafy vegetables. So spinach, kale, broccoli, those kind of foods that are high in antioxidants that are helpful. And avoiding tobacco products, cigarette smoke, but also vaping, chewing tobacco, things like that have been shown to cause progression here. We already talked a little bit about what this Amsler grid is in terms of monitoring macular degeneration at home. There's another device that's out there that can be used for home monitoring called a 4C device. This is sometimes helped paid for with insurance companies, depending on your insurance, but you'd basically kind of look in here, you'd see a line of dots, and you would need to kind of click on where you might perhaps see an elevation within that wave. And that might, and that information is sent to your healthcare specialist to kind of trigger that, hey, you might need to come in for an exam and look to see if there's any issues acutely going on with the macular degeneration. When it comes to people with macular degeneration and vision loss over time, unfortunately, we are sometimes somewhat limited in our options to make someone's vision better. And there are eye specialists and occupational therapists who are what we call low vision specialists, who kind of work with a patient to make the most of the vision that they have, getting a lot of magnification, very special and specific lights, orientation and mobility training, and assistive technology to help individuals who maybe don't have the quality of vision that they want to have. Well, when it comes to dry macular degeneration, what are some future treatments? We're looking at some treatments for dry macular degeneration that are kind of anti-inflammatory to reduce part of the inflammation seen as the disease. Neuroprotective pathways, meaning things that are going to protect cells to keep them from dying off. And neuroregenerative pathways, meaning things that are going to look at trying to bring back tissue that has been lost and died off. The difficulty with these dry macular degeneration treatments is that we will often get them through a trial, but unfortunately towards the end of that trial, they're not working. So they fail to show that they actually do anything to slow the progression. And that's been part of our issue with, in particular, treating dry macular degeneration. You might read some about stem cell transplants or stem cell treatments that are out there as well. This is something that has some promise for the future, but is still a bit of a ways off and needs to be done with extreme caution, as kind of unregulated stem cells injected in the eye several years ago in some clinics led to severe vision loss in patients. So what is wet macular degeneration? It's caused by abnormal blood vessels that grow beneath the retina. And these fragile blood vessels have a tendency to leak blood and other fluids beneath and into the retina. And here's an example of kind of a net of abnormal blood vessels here that have bled into and beneath the retina. This is typically going to cause a much more rapid and severe decline in vision, especially if left untreated. And about 10% of people who have dry macular degeneration will go on to the wet form of macular degeneration. And typically, if people have wet macular degeneration in one eye, they have a much higher chance of having wet macular degeneration as well in the other eye, about a 35% chance. So as we showed some of those images of those kind of sawtooth bumps beneath the retina, here's an example of this abnormal blood vessel net beneath the retina. And these black areas here are going to be fluid that's beneath the retina. So this is an example of a patient who has wet macular degeneration in the right eye and dry macular degeneration, or probably not really much of any macular degeneration, in the left eye. So how do we treat it? Back in the day, this used to be treated with a laser therapy that would burn the abnormal blood vessel in order to cause it to stop bleeding and leaking fluid. It was fairly effective, but no longer really used because the laser destroyed healthy retina and sometimes left people's vision worse off than it was before treatment. Standard of treatments currently are medications that go into the eye itself with an injection in order to try to get those blood vessels to stop leaking. So one of the main signals of that is what we call VEGF, vascular endothelial growth factor. This is one of the signals that causes these blood vessels to form and keeps these blood vessels functioning. So there are medications that are essentially blockers or antibodies to that signal that bind that signal and work to remove them from the eye. There's currently 4 products that are out there that are used: Avastin, Lucentis, Eylea, and Beovu. Beovu is our newest drug that came out. It's meant to last one of the longest amounts of time. However, shortly after release, there became some concerns for inflammation in the eye that have paused the use of this drug in the majority of cases. In addition to injections, occasionally there is treatment with something called photodynamic therapy, which is a light sensitive medication called verteporfin, which is injected into the body. And then there is a light or laser that is shined onto the affected area to kind of activate the medication and get those abnormal blood vessels to coagulate. This is a treatment that's very different from the other thermal lasers because we kind of consider it a cold laser. It doesn't really use any heat energy for the most part and does not damage tissues kind of typically outside the direct area of treatment. Occasionally, surgery is done for patients, usually in the setting of a really massive, large bleed, where occasionally treatment will be done to remove the blood or try to displace the blood. This is fairly uncommon, but one of the few settings where we might see surgery being done in this case. So a lot of questions will come, well, what medication should we use to start treatment? How often do I need to get treatment? How long do I need to get treatment? And will the injections hurt me? And these are great questions that you'll want to have typically with your ophthalmologist or retina specialist. A lot of times medications that are started are going to be determined between you and the treating physician. A lot of times people, at least initially, are going to need an injection approximately once a month, at least for the first few months, and then that can be spaced out depending on your response to treatment. And injections can typically be needed for someone's kind of indefinite life, depending on how active the disease is. Most people are going to, every once in a while, need an injection to kind of keep things in remission. But occasionally people are able to move away from the injections if we get it quiet and dormant enough. When it comes to injections hurting, different physicians use different methods to do the injections, but we usually do a really good job of numbing the eye. So typically people don't feel anything, or maybe a pinch or pressure for a split second, and that's about it. It's very well tolerated by most patients. So where do we go from here? Where are some future treatments specifically for wet macular degeneration? We're looking at longer lasting drugs. So instead of needing to do an injection every month or two, maybe going longer, but also looking at different kind of combination targets for treatment. This is a medication that will hopefully be available either later this year versus next year in 2022. In addition to binding that anti-VEGF that we talked about, faricimab is also an antibody that blocks Ang2 or angiopoietin-2, which is another one of those signals for blood vessel growth. And in clinical trials, almost half of patients were able to maintain good quality vision and keep their disease in remission with injections every 16 weeks, essentially every 4 months. That's fairly comparable to Eylea, which is a really common medication out there, which is typically an injection every 4 to 8 weeks. A really exciting treatment that will most likely be available with potential FDA approval later this year is what we call the port delivery system. And this is a reservoir that would be surgically implanted in the operating room in the eye with a small procedure. And it contains a reservoir here, which will have a super concentrated dose of one of our medications, Lucentis. And that would be slowly administered into the eye at a continuous rate. Every once in a while, when we see that the medication is wearing out, we would be able to refill that device in the office, in clinic. And on average, in their clinical trial, once it was surgically implanted, people didn't need a refill for the first 15 months on average. So that has a lot of promise. Gene therapy is another promise in the future, and hopefully something that will be on the horizon. Basically using a virus or other vector to deliver a deficient gene or other target to maybe produce a medication in the eye or help regenerate tissues that have been lost or damaged. So that about sums it up for my presentation. I think that leaves us a few minutes for some questions that I think I see in the Q&A box.
Yeah, absolutely. I'll go ahead, Matt, and just read some for you here. A couple of them were a little bit situational. So I think the biggest takeaway for the questions on this one is if their parents had macular degeneration, but they've spent their lifetime with healthy habits, making healthy choices, protecting their eyes with sunglasses, any kind of thing like that, are they still, is that connection with the family history still relevant?
It's a great question. Unfortunately, I think sometimes we wish our genes weren't as strong as they were, but it still does remain a risk factor. I think it's very important to continue to do those things to minimize your risk, eating a healthy diet, living a healthy life, things like that. But the genes do play a role, and that person is still at increased risk. So especially as they're getting up in years and aging, they do want to be seeing their eye care specialist for Probably screening exams, every year or so
Mhm.
with a family history.
Great. So, would you be able to address like pressures that people feel in their eyes? So when are you should you be concerned, excuse me, and then what should you do if you're experiencing that?
Someone feeling pressure in the eye.
Uh-huh.
Um, Pressure is a little bit hard sometimes because the eye and the head sometimes is not, nerves are not as well localized as we think they are. So sometimes we're going to feel a pressure in the eye, maybe if we have just a regular headache, if we have perhaps sinus blockage and sinus pain. Sometimes dental pain and tooth pain will be associated with kind of pain around the eye. And so sometimes it's a little hard to tease out, but usually if it's something that is ongoing or worsening, and especially if it can't be controlled with medications like Tylenol or ibuprofen, then it's worth seeing your eye care specialist about.
Great. So would you be able to touch a little bit on floaters, and are those of any concern?
Yes, floaters are interesting. So floaters essentially in the back of the eye, our vitreous cavity or vitreous humor is a large cavity. It's about 4 milliliters in volume, and it's mostly water, but there can be collagen and other proteins within that vitreous that give it some structure and support. And especially as we kind of age over time, those proteins will kind of congeal and coagulate together and clump together. Um, and they'll cast a shadow and cause a little floater in the eye. Everyone usually has some benign floaters that are not much to worry about, but in particular, if someone has, say, a history of diabetes and they get a lot of floaters, that can be a concern for really advanced diabetic eye disease. And usually as we age, or if someone's really nearsighted, they'll typically go through an event in their life where the vitreous of the eye will kind of naturally start to pull away and separate from the retina. And when that happens, typically people are going to notice a really large sudden change of floaters in their vision, along with perhaps kind of flashing lights, almost like a strobe light. And usually when you notice a change like that in your vision, it's going to be recommended to get in fairly quickly with your eye specialist for an examination to make sure everything's okay.
Awesome. So does anything like astigmatisms affect macular degeneration when you age?
That's a good question. They don't. The eye, as we talked about, being a little bit like a camera, the astigmatism is going to be in the cornea, in the very front of the eye. Thinking about it, in a camera, the very front, where the image is kind of first entering the camera. And instead of the cornea being shaped like a sphere, like a basketball, it's a little abnormally shaped like a football. And that causes lights to sometimes be warped in how they enter the eye, which is usually corrected with glasses. But astigmatism has no impact on macular degeneration.
Okay, great. This next question is a macular buckle part of the dry or wet syndrome?
A macular buckle is not part of that syndrome. There are things called scleral buckles and macular buckles that will be used in the setting of retinal detachments in order to fix a retinal detachment or sometimes an issue with the macula from someone who's very nearsighted. And those are um, done with surgery and not related to AMD.
Okay, great. So do symptoms like dry eye symptoms affect dry macular degeneration?
Yes, another really good question. They don't. The typically the outside of the eye and the inside of the eye are a little bit of kind of separate environments. So the retina doesn't really have many pain. Actually, the retina doesn't really have any pain receptors. So you can't really feel macular degeneration or feel what's going on in the retina. And um, the dry eye is once again kind of in the front part of the eye, typically dealing with the cornea. And so those are two differently connected,
At least a little bit
but
comforting, right?
similarly named.
Yeah. Okay, so this next question goes back to the AREDS vitamins or the drops that you were talking about.
Yes.
So is it of value to take more than the recommended 2 pills per day? Would that make any significance in, just this taking care of it?
Yeah, so that the AREDS 2 vitamins are, it's an oral medication. It's a vitamin taken in addition to a regular multivitamin. And I usually don't recommend to patients to take over and above that amount. The reason for that being that some of the vitamins in there, in particular your vitamin E, is fat soluble, meaning whereas vitamin C is something that's excreted by the kidneys and you can take super mega doses of it, vitamin E will sometimes build up in the body if taken in really high doses. And that can lead to sometimes thinning out of the blood, liver issues, things like that. So I usually recommend my patients to take the standard AREDS 2, and if they wanted to do something over and above that, then they can consider maybe a supplemental lutein or zeaxanthin that are kind of freestanding antioxidants.
Great, awesome. So I think we have time just for about one more question. So for the injections, what are the common side effects that people experience?
Yes, so for injections, a lot of people will sometimes have a red eye afterwards, or a spot of redness on the eye simply from the needle nicking a small blood vessel. Those are harmless and they just usually go away in a few days or maybe a week. To clean the eye and sterilize the eye, we use typically an agent called betadine, or it's kind of an iodine-based product, and that can burn and sting the eye a little bit and irritate the eye. So we try to do a really good job of rinsing that out afterwards to reduce that irritation. But occasionally people will feel kind of a burning, scratchy feeling, which is usually relieved with eye drops. Very rarely there can be issues with eye pressure being high or low after an injection, inflammation, and very rarely an infection in the eye after an injection.
Well, wonderful. Thank you so much for your time today, Dr. Manry. It's very exciting too about what's maybe to come late 2021, early 2022. So hopefully next year when you join us for this, you'll be able to talk a little bit more about your experiences.
Absolutely.
Right.
Absolutely. Well, thank you for having me.
Yes, great. We will go ahead and transfer over to Dr. Burton and let her get started with her presentation on blurry vision. I know there were a couple questions too today that we weren't able to get to for Dr. Manry. So this webinar is being recorded and these slides will be available on our website. So we'll get into that a little bit more at the end, but if there's anything that went unanswered that Dr. Burton maybe can't answer, we'll be able to get you the good contact for that as well. So, all right.
All right, thank you, Lindsay. While I'm starting to share my screen here, let's see here. So I am, like they said, Dr. Melissa Burton here at the Eye Care Center of Northern Colorado. I grew up in Michigan. I did my undergraduate training at the University of Michigan, then got my doctorate in Chicago at Illinois College of Optometry. I did my residency in primary care and ocular disease. I've been practicing in Louisville, Colorado for the last 5 years and just joined the Eye Care Center here in January. So I really wanted to review just in general how the eye works. Dr. Manry did already go over a little bit, but I really wanted to address every aspect of why patients, specifically in the aging population, may come in to see us, just because there are many causes, but I tried to focus on the most common ones that I get asked about. So you see in the diagram here on the left, just as the light enters the eye, it needs to pass a clear cornea. It then goes through your tear film, well, first through tear film and then your cornea, passes through the pupil, which is actually just a hole to go through your lens, and then focus back on the retina. We need every kind of aspect of the eye to work properly to get clear and comfortable vision, and that's my part, is to really assess every aspect of the eye to determine what is the cause of our blurry vision. So when I see patients come into my office pretty much on a daily basis with, the complaint of blurry vision, because there are so many causes, I like to really break it down into why are we getting this blurry vision. So the first question to ask yourself is maybe, was this a sudden onset or gradual? Obviously, we're more concerned about sudden onset. Does that blurry vision fluctuate throughout the day, or does it stay pretty consistent? And then if you know you have other systemic health concerns like diabetes or high blood pressure or even other known eye conditions, how stable are those? And is that something we need to factor into our decision? So common causes for a gradual decrease in vision, we can assess cataracts, like Dr. Manry already covered quite in length, is macular degeneration, although that can be a more sudden onset for some patients. Dry eyes, again, can be sudden, but generally are pretty gradual. Glasses prescriptions, which I do on a daily basis, can be a big role in our vision changes. Something that patients maybe don't think of as much is what we call binocular vision problems. It's basically how the eyes work together. Unfortunately, that does tend to decrease as we get older, and those symptoms can be a little more sudden or a little more not as obvious, and patients might not think of those problems. And then glaucoma is a big question I get a lot. It typically does not cause central vision changes, so it's more of a disease that we don't think of causing many symptoms, but I do get a lot of questions, so I did want to cover glaucoma a little bit. So a cataract, what is a cataract? So we have a lens located right behind the iris of our eye, that colored part that is focusing light onto the back of the eye called the retina. If that gets cloudy, we're going to have blurry vision. It is the leading cause of vision loss in adults over the age of 55. And it's the leading cause of blindness worldwide. So we do see this in every age across the country. So if we want to have clear vision, as we can see with this soccer ball, we have light entering the eye through, again, that clear tear film, the clear cornea, but specifically a clear lens. You can see how if that lens becomes cloudy with age, it will definitely not focus the image as we would like. So then getting into the symptoms of a cataract. The typical symptom that most patients will say is that their vision is blurry. Vision classically, as you can see on the eye chart there, crystal clear vision is our 20/20 marker. We used to basically say that we were ready for cataract surgery once we hit 20/40. A lot of insurance plans have changed that guideline, so we don't always go off of just blurry vision. I like to also point out that you really need to have an eye dilated, as you can see at the top photo, because the lens is situated right behind the iris. For a lot of patients in the aging population, their pupil size is quite small, and you really just can't get a good view of the cataract or of the lens unless they're dilated. So I know that's not always a fun part of an eye exam, but you do need to be dilated. And then our symptoms are at the bottom. I mean, we can have anywhere from normal vision where the cataracts are really, you're not even noticing it. We just see it clinically. Once they've progressed more, we can have a yellowing of our vision. That again is very subtle. We might not notice it until after the cataract has been removed. We can just have that blurry vision, or we just feel like the vision has become dim over time. And then again, the distortion of vision, that's more like when we see with driving at night with car lights becoming more of that glare problem. So how do we slow their progression? A lot of it is about sun protection, not smoking, that healthy lifestyle, a lot of things that Dr. Manry touched on with macular degeneration. But we also just want to accept that some of it are these biochemical properties of our bodies that we cannot do anything. So I have a lot of patients that come in their 70s and say that they have worn sunglasses their entire life. They don't smoke. They really have been quite healthy, and they're honestly surprised that they have cataracts. Whereas I just say it's really part of the aging process. The biggest question I will get on a daily basis is just how do we know when we're ready for surgery? That is why typically when we have just a general complaint of blurry vision, you're going to see me first, but maybe versus one of my retina specialists, is there could be many reasons. It might be as simple as glasses can get us back to clear vision. So as long as we can't get our vision back to 20/20, we might be ready for surgery. You might be 20/20 in your glasses, but night driving has just become too difficult. You know, you say you're very functional throughout the day, but you just aren't able to go see your grandkids down in Pueblo because the night driving has become too difficult. That glare is really a deciding factor. What if we're not ready for surgery? Whether it's, you know, your eye care specialist says that you're not ready, or you just feel like, you know, there's a pandemic, maybe not the best time to be getting cataract surgery. We always want to keep our glasses up to date. Any little bit I can improve a patient's vision with glasses, I try to do, because those can make some big differences. We always want to use a lot of light when we read. hopefully real natural light. Artificial light sometimes is even a little more challenging. Night driving, I'm just kind of being smart about it. If you're not comfortable, then don't put yourself or others at risk. Try to, keep to daytime activities. And a lot of patients think that, well, I've been used to maybe 2-year eye exams. We might need to follow you more closely, definitely within a year and sometimes even 6 months. I'm not going to get too much into macular degeneration just because Dr. Manry did such a nice job, but macular degeneration is often a first concern that patients will come in for me. As much as macular degeneration is more prevalent, we do see it a lot in Caucasians here. It's just not always the cause of that blurry vision, and often it's more rare that it is the cause. So I'll skip that. Symptoms can be drastic, but I did like this presentation at the bottom that you can be basically asymptomatic with macular degeneration. You may just have those little protein deposits, which are called drusen, and they don't actually cause any changes in vision. You can progress to more severe cases, but again, we need to distinguish, is it the macular degeneration that's causing the blurry vision, or we just need to update our glasses, or we have cataracts. Again, with Dr. Manry, a lot of patients ask me the general questions. How do we slow the progressions? What do we treat it with? What can we expect next? How often do we need to be seen? These are going to vary for every patient. Slowing the progression is the same things that he talked about with sun protection and a good balanced diet. Treatments are needed typically only when we develop the version of wet macular degeneration where there's active swelling and active bleeding within the retina. I like to be very generic about what to expect because I don't want to set improper expectations for patients. I mean, macular degeneration can vary so much where you could see a patient stable for decades with the same amount of drusen in the eye, and then you can see someone who develops it rapidly, what seems like in a few days, and needs to be seen by a retina specialist immediately for treatment. And the same thing with how often we should be seen. I mean, it really depends on the patient. We are never going to let you go for too long of a time period just because we do want to check for subtle changes, but some patients will need to be seen every 4 weeks and some people may not need to be seen for 6 or 12 months at a time. Dry eye in our climate, with our climate here, I think is really one of the most underestimated causes of blurry vision. As everybody knows, everything is dry out here. Our skin is dry, and so our eyes can absolutely be dry. And in that first diagram I showed, light needs to enter first through a thick and healthy tear film before it can even hit the cornea and go through a clear lens. So we really need to start off at the basics of why dryness is such a common cause of blurry vision. It can be more obvious with dryness, scratchy feeling, tearing, redness. You can even get a dull to sharp pain, but you don't necessarily think of fluctuating vision or blurry vision as, that dryness is the cause of that blurry vision. A lot of our aging population is on many medications, and so those medications can dry us out, which we're not going to stop those medications because they could be a life-saving medication, but we do need to remember to stay hydrated just because we're taking those medications. A lot of us, especially during a pandemic, have had extra use on books and computers, and it's not the device of being an electronic device, it's more that we're just focusing up close. Our blink rate is typically about 50% less when we're on these devices and trying to focus up close. So we need to consider, using supplements like artificial tears or staying hydrated when we're at a computer to combat that. Another big thing in Colorado is our allergy seasons. A lot of patients take oral antihistamines because we have so many other symptoms with nasal drip and everything, but those will dry us out. They're drying us out on a good level for our, systemic symptoms, but they're not good for the eyes. Another underestimated kind of aspect of just how powerful a glasses change can be. So a lot of patients are mostly coming concerned because they've had the same glasses prescription for 20 years, 10, 20 years, and they say, there must be something drastically wrong with my eyes because I'm now blurry and I haven't had a glasses change or needed a glasses change in 10, 20 years. You also want to keep in mind that those glasses changes can be subtle. So maybe your previous eye doctor has said you don't need to update your glasses, but those little small changes will add up over time. I always want to know, can we get back to 2020? I don't think there's ever really a time in anybody's lifetime where to say, well, I shouldn't expect to see 20/20 because I'm 75, 85 years old. I always need a reason. So I'm going to try to always get you back to 20/20 before I say that there's something else going on. We may need to change glasses in less than a year. That may seem very shocking for some who go 10 years between changing glasses, and all of a sudden we need to change them in less than a year. That is common, unfortunately, with age and with cataracts and other problems. Another thing not to underestimate is when you've had glasses for 10 years and you work in a shop sometimes, or you have your grandchildren play with them, is that they get scratches, the coatings wear off. You kept them in your car and those coatings can start to crack and flake off. Those can cause distortions. And so we may keep the prescription exactly the same, but you'll still see better just because of the quality of the lens has improved. I wanted to kind of demonstrate a little bit just that we might not be needing cataract surgery, but the actual formation of a cataract can change how light enters the eye. So as you can see on the left there, we focus light, sharply with a clear lens, but with a cataract, it's kind of diffused, but it can also induce just becoming more or less nearsighted. So if light enters the eye and hits a clear lens on a properly shaped eye, it'll focus on the retina on the back of the eye and give us a clear image. With the development of cataracts with that cloudy lens, we can have a nearsighted shift or a farsighted shift. And so we may be able to prescribe glasses just to negate that difference. And now we're back to 20/20, but the cataract is actually the cause of that glasses shift. This was that area where I like to definitely bring up in my aging population, just our eyes are not working as well together. And so we need to determine the difference of, when we have either eye strain, which is just I feel more fatigued when I'm working, versus I truly see double of two images. So some of those symptoms can just be an updated prescription. Again, we have 20-year-old glasses. They're probably going to need to be updated. We might not feel as much fatigue with that. But then we can also have dry eye, other ocular surface diseases such as, allergies or sun damage to the front part of the eye. Those can cause problems of eye strain. But then we get into more muscle weaknesses, and that's going to be maybe more of a concerning area. Why did we have this more gradual or sudden onset of a muscle weakness? To demonstrate just why this can happen, we can see with the upper right image there that the eye is surrounded by muscles that are controlling, upward, inward, outward movements, but then all those muscles are connected by cranial nerves that then send the signal to the brain. And so that pathway can be disturbed in the brain, but it shows up as an eye problem. And so when we think about more sudden changes in, say we have all of a sudden I started seeing two when I would read, or I have two sets of car lights. After we rule out cataracts and other things like that causing those symptoms, we need to look at the eye muscles as well. And again, it may need imaging, whether it's an MRI or a CT, to rule out something more serious, just because all of those nerves are being connected to the brain that control the eye muscles. Again, glaucoma is one of those conditions that I get asked a lot about, but it is a very complex disease, as you can see there, but it damages the optic nerve, which is connecting the eye to the brain, and it does give us irreversible vision loss. So it's important to catch it early because it is progressive. It is the second leading cause of blindness in the world, according to the World Health Organization. It does affect certain populations more than others, but again, it's a disease of age. We have risk factors with family members already diagnosed, diabetes, and then people who are very nearsighted. Well, the basic anatomy of why we have increase in pressure in the eye, the pressure is measured with that blue light, as you can see in the upper right, which many are familiar with. But there's a constant fluid production in our eye. As you can see on the left there, the muscle there is producing the eye. That fluid needs to come out of our pupil and drain, and that is a constant process all day long. And when that process is interrupted, the eye pressure can increase in the eye. With increased eye pressure, from our diagrams there, you can see a normal optic nerve on the top. We think of it like a donut. We have the donut, and then we have a hole or an opening that allows the blood vessels to pass in and out. We would like that hole to say 50% or less of the entire optic nerve. But then in glaucoma, we'll see that that hole to that donut is now increasing in size, 70, 80, 90%. If you have a 90% opening there, you only have 10% remaining tissue. So when you see the progression of glaucoma, you start to lose your peripheral vision. A lot of patients are labeled as a glaucoma suspect, which means that your optic nerve may look suspicious because it is a 60–70% opening, but we actually don't see any damage to your vision yet. That is tested with a visual field machine that you see in the upper right there. But glaucoma is classically a very subtle disease just because it is in the periphery of your vision. It's not central like macular degeneration. For glaucoma treatment, it ranges very, a lot of people are just monitored when we're a suspect. We'll do testing and follow you closely. But once we're actually diagnosed with glaucoma, we can use eye drops. We can do more aggressive treatments of laser or even surgery. Those are a lot more rare. Typically, we do quite well with just drops. How often we need to be seen is very similar to macular degeneration. It depends. Unfortunately, you have to watch your pressure closely to make sure that you're responding well to eye drops. And so we might need to do 3 or 4 month follow-ups, or in the beginning, even a few weeks at a time, just to make sure your eye is not showing any progressive loss of damage to that optic nerve with the pressure. But the biggest thing for my part, I may send you to a glaucoma specialist that you may be on 3 or 4 drops for, but then you come back to me with blurry vision. It's because those drops can also dry us out. So again, going through checking for cataracts and macular degeneration prescription changes, but it can be something as simple as that ocular surface is just so dry that we do not have good vision. And so you need to continue your glaucoma medications, but we need to supplement maybe with artificial tears or other techniques for dry eyes. The more sudden things are obviously more serious. Wet macular degeneration, like Dr. Manry touched on, that's going to come on quite suddenly, and I'll need to get you to a retina specialist right away. We can have neurological things going on, such as a stroke. We can have traumatic things. Those are more obvious. If you know you got poked in the eye with something, you're going to see those problems. But then we can get into other problems like diabetic problems with the eyes, or if we're taking a high-risk medication that has a complication. So when it comes to strokes, we can have strokes specifically in the eye or in the brain. In the eye, it's a little more obvious that you can see in the upper left picture there that some sort of embolus has moved from either our carotid artery in our neck or maybe from our heart and clogged into one of these tiny blood vessels in the retina. These are some of the smallest blood vessels in the body. So if you're going to throw a clot, this is where it could collect, and you can see it right off the optic nerve there. All that whole blood vessel is kind of damaged and blown out, and you see all that bleeding. That will cause a pretty sudden decrease in vision. But we can also have that same sort of clot travel to the brain. We will see it as maybe a loss of part of your vision. You can see on the right there, those are portions. It's very useful to know what portions of your vision are missing, because we can then trace it back to which part of the brain may have seen that stroke or that clot form. Diabetes is the leading cause of blindness in adult Americans. These blood vessels basically become dilated and weak and start to leak either fluid or blood. That will cause, if it comes on rapidly, a sudden decrease in vision. You see on the bottom right there, those are all new abnormal blood vessels. They are not as strong as your normal blood vessels, so they will leak blood and fluid, and that will cause swelling. You can see in that bottom left, similar to swelling that can be seen in macular degeneration, but this is a different cause. You can see the incidence of diabetes is projected to go up by the National Eye Institute there, and so it's an ever concerning cause for us. One of the other main questions I ask patients is just, is it a blurry vision that's consistent or it's fluctuating? Consistent things are a little more obvious. Fluctuating can be something subtle. You can have those eye muscle problems that are fluctuating. I only notice it when I'm tired at the end of the day. Dryness can cause fluctuating because I'm typically dry when I wake up because we're not blinking all night, so we dry out there. But it really helps us decide what condition could be causing this blurry vision. If we look at, is it consistent throughout the day, like macular degeneration, or is it fluctuating like with dryness? Lastly, we kind of want to worry about our health conditions. Obviously, these conditions can cause a whole slew of problems, not just in the eye. High blood pressure, high cholesterol, thyroid eye disease. Thyroid eye disease can be with our thyroid being not working properly. It could be the medications that we are taking to try to control the thyroid problem, or it can be the muscles are not working together, so it comes in many forms. There are many medications out there that cause blurry vision, some that are treating some very important conditions like lupus or rheumatoid arthritis, but we need to monitor the health of the retina to make sure that they aren't causing any problems. Migraines can be more subtle. Typically, we think of that as, again, a intermittent problem, meaning not happening all the time, but that can cause a lot of visual symptoms. And I always like to bring up our more mental health disorders with Alzheimer's and dementia, because you may be caring for a family member or a spouse that has one of these conditions, and they tell you that they have lost their vision. And, it's always important to know that we need to do an eye exam to provide, really the cause for it. Did they truly have a change in their vision, or is it something else going on? The biggest thing I want my patients in my chair to remember is that we really need to see you to be able to diagnose these problems. I have so many times where patients go for months with a problem that needed to be treated right away to have a good visual outcome, and they decided that they thought it would get better, or a friend told them that they would get better on their own, or you did the inevitable, what I call Dr. Google search, because Dr. Google knows everything, but it's really just important to see an eye care specialist. And that's all I have.
Perfect. Thank you so much. I will go ahead and just dive, Dr. Burton, right into some of the questions that we had come up. So are there treatments available for binocular vision issues?
Yes, binocular vision in the aging population is very different than how we approach binocular vision issues in a younger population. Typically, if it's a sudden onset, we want to rule out, stroke or other brain problems to make sure that we're not missing something more serious. But typically, if our eyes are just not aligned, we kind of accept that. We know that they're not going to be aligned. They're not going to get better with age. And so we can put what's called prism in eyeglasses, and that just shifts the image in an appropriate way that we allow the eyes to sit out or sit in, and we don't actually need to do, any sort of therapy. It's just more to help the eyes be where they want to be.
And then next question, so going back to dry eyes, what's your advice for improving dry eyes? I mean, how much improvement really is possible?
Yeah, it's a condition that we need to stay on top of. It's unfortunately a, chronic progressive problem. And so in our climate, I want my patients to stay hydrated. I want them to have good supplements in their diets with omega-3s. Supplementing with artificial tears can be enough, but then there's also a ton of artificial tears. So coming in and getting the proper recommendation, never get the red out kind of drops. There's a lot of correct drops and a lot of incorrect drops. We can go to plugging our tear ducts so that the tears don't drain as quickly. There's actually quite a few options, but we do need to, assess which part of the dryness is really causing the main problem.
Okay. So can your eye muscles be strengthened by exercising them in any way?
That is a good question, and one I get often. We think of strengthening our eye muscles as more of something we can do with vision therapy when we are much younger in age. Typically in our aging population, they're pretty much where they're going to be, in that we don't really have any exercises, unfortunately, that can help with that.
Okay. So as a specialist, what do you recommend for a blocked tear duct caused by a recent trauma?
Well, it kind of depends on why is it. We can have just what we call general stenosis, meaning just the duct has kind of narrowed with age. That's a surgical intervention. If there's traumatic, it can be surgical too. Sometimes it's just we have a lot of mucus buildup, and we actually need to force saline solution down that tear duct to actually unclog it. Sometimes it's a mild infection. We need to go on an oral antibiotic. It actually depends on a lot. We have to figure out the cause of the blocked tear duct first.
Okay, great. So this next question is a little bit about contact lenses, actually. So this person wears gas permeable contact lenses for better vision than with the soft ones. So has there been any improvements or changes in soft lenses lately?
Soft lenses, in Colorado, we definitely typically stick with daily replacement. Those are typically the healthiest. They are the most expensive, but they are the healthiest for the eye. We've definitely come a long way, but it's still a contact on your eye. Like, patients do not have too high of expectations here. That is not the healthiest option, no matter what kind of lens we have on the eye. It's very rare that we promote the contact over no contact, but we're a very active population, so contacts are very necessary. And so it's always, again, good to check with your eye care provider to see what's out there.
Okay, great. So when you come in and, you have your eye exam and you have those different stations that you kind of do for those tests. So the one that has the pressure, or that measures the pressure in your eye, when is like when do you need to be concerned? The pressure that's measured, when is that kind of?
That's a good question. Pressure needs to be measured accurately. There are, unfortunately, a lot of different ways to measure your pressure. So when you think of that puff of air that a lot of patients are nervous about, that's what we consider probably the least accurate form of pressure testing. So we'll use some different instruments to check your pressure, but pressure, just as in glaucoma, is very relative to the patient. So you generally say you want a pressure of around under 21, but I have patients who their optic nerves handle pressures of 25 and it's no problem. Some patients can only be pressures of 15 before we start to see damage to the optic nerve. So I know a lot of patients come in and immediately ask, what's the pressure of my eye? But we need to really take a look at the entire optic nerve health and the entire eye health to be able to answer that question appropriately.
Okay, great. Well, thank you so much, Dr. Burton. We are right about at our 1 o'clock time. So I just wanted to thank you so much for your time. And like I said, for Dr. Manry, if there were any questions that went unanswered, this webinar is being recorded and will be available on our website, dailycamera.com/aging. And you can find it there and all of our resources for the webinar series as well. So thank you so much again.
Yeah, absolutely. My pleasure.